Okay, so I have no disclosures, and this one's the same. So the main sources for the DVT and PE guidelines come from CHEST. Probably everyone in this room has seen it. The latest edition came out in 2012, which was pre-direct oral anticoagulants. And so they had to update in 2016 with the direct oral anticoagulants, and then the most recent update was 2021. So we'll start with that. So in terms of medical management, which I guess is the least sexy part of all the talks about PE, but we're just going to address medical management, and then I guess you guys go into devices. So the questions are all PEs treated? When should patients be admitted? What are the options for medications, and how long do we treat? So for the people who are here for DVT, the isolated subsegmental PEs are like a caffeine DVT, meaning because they're so low risk, we don't necessarily need to treat those. And so if somebody has an isolated subsegmental PE, you look for a proximal DVT. If you don't have one, you can just watch it. If the patient is low risk, meaning for bleeding with anticoagulation, you can just treat. And then at the other end of the PE spectrum are the acute PEs with hypotension, clinical instability, and those are the ones that are treated with catheter-directed thrombolysis, systemic thrombolysis, embolectomy. And then basically everything else in the middle, everything that's not this isolated subsegmental and everything that's not risky, we just treat with anticoagulation. And the caveat is always, if the patient decompensates somewhere along the way, then you go to the more aggressive treatment. So the benefits of early anticoagulation were seen years ago. This paper is from 2010, 400 consecutive patients admitted to the ER with acute PE. And what they found was starting heparin in the ER saved lives. So if you look at hospital mortality, the mortality for people started with heparin in the ER was 1.4% versus 6.7%. And there was actually a huge reduction in 30-day mortality too. Then looking at the graph on my right, I guess everybody's right, they looked at whether having a therapeutic PTT mattered, and reasonably it did. So for patients who had a therapeutic PTT on heparin, there was a significant decrease in mortality in the hospital and 30-day mortality. And in addition to the mortality difference, ICU days were less, length of stay was less, and so the big lesson is anticoagulate early. In terms of whether people need to be admitted, which has always been kind of a hot topic, the first large trial that looked at this was published in The Lancet in 2011. And basically what they saw is outpatient, and I guess I should have specified here, the inpatients in this study had no complications. Outpatients, one patient had a recurrent VTE, one patient in each arm died, major bleeding in 2 patients. So the risks were seen as very low, although the risks were with outpatient management. The big important message is this study was done in the Coumadin era. So everyone in this study was treated with either low molecular weight heparin or Coumadin, which certainly has higher risks than what we use today. And the big study looking at inpatient versus outpatient was a meta-analysis of 19 studies. The important thing to realize on this one is it was not 19 studies that compared inpatients and outpatients. It was 19 studies, some of which were outpatient, some of which were inpatient, and they just pooled all the data for 2,000 total patients. They saw no difference in recurrence, inpatient or outpatient, no difference in major bleeding, inpatients or outpatients, but there was a higher mortality in people who were not admitted to the hospital with a PE. Again, the modern take on this trial and the previous one is the increase in mortality is probably because of the issues with Coumadin. Either people were overtreated and had bleeding, undertreated, etc., and probably the risk is lower with what we have today. Which brings us to what we have today. So the 4 major drugs that are used for DVT and PE were all compared to warfarin. Sorry for the people who heard this piece in the DVT talk, but all published in the New England Journal. And the differences between them are important because those are the differences that dictate what we use. So dabigatran and edoxaban both have a loading period with heparin, which was similar in those trials to the Coumadin arm. So everyone got heparin first and then got their drug. Different for rivaroxaban and apixaban, which is nice because these can be purely done as an outpatient. And so generally for people that you're treating outpatient, the easiest thing to do is stick to all oral. There is a renal dose that you have to use for edoxaban. The other 3 can be used as long as creatinine clearance is above 30. And then the biggest, most important distinctions are where the balance is between recurrent clot and bleeding. So dabigatran, pretty equivalent to warfarin in terms of recurrent clot, less bleeding. Rivaroxaban, much better in terms of recurrent clot, no improvement in bleeding. Apixaban, the improvement's not big, but there's a huge reduction in bleeding, which explains some of the big takeoff of this drug. And then edoxaban, big improvement in reducing risk of clots, not so much of an improvement in bleeding. And so usually when you decide what to use, you're balancing all of these different features. The special cases, antiphospholipid antibody syndrome with clot gets warfarin. Cancer, we'll talk about. Renal disease was enough for me. Obesity we'll talk about, and pregnancy is still low molecular weight heparin. All of the other small molecules cross the placenta, so are not safe to use. So looking at the direct oral anticoagulants and cancer, all three were compared to dalteparin, which is a sub-Q. Rivaroxaban is only retrospective. All three reduced the risk of a recurrent clot significantly. However, the risk of bleeding was the issue. So for apixaban, the bleeding risk was equivalent. For the other two, there was more bleeding with the direct oral anticoagulants compared to dalteparin. And so the oncologists have embraced apixaban, or low molecular weight heparin, as the drug of choice and really are not using the other two. So the question of DOACs and obesity has come up and continues to come up a lot in terms of drug choice. In the original trials, the only oral anticoagulant that was studied in BMIs over 35 was rivaroxaban. None of them addressed patients with a BMI over 40. And then in post-marketing studies, post-marketing data, both rivaroxaban and apixaban were used in patients whose BMIs were over 40. So the consensus of the International Society on Thrombosis and Hemostasis is BMI up to 40, you can use any. All of these drugs work closely enough, so even though they were not all studied, it's safe. For a BMI over 40 or a weight over 120 kilograms, it's only apixaban or rivaroxaban. So those are the only two. I like including this one because PE after bariatric surgery is something probably many of us have seen. This slide is where all of the different oral anticoagulants and warfarin are absorbed. So in the stomach and the first part of the intestine. And looking at the different procedures that are done, you can see how some of the absorption would be affected depending on where the surgery affects the stomach or the intestine. And so the consensus is probably the absorption of all of these medications are affected by surgery. Apixaban probably the least. And so if there is a PE after bariatric surgery, you use low molecular weight heparin for the first 30 days at least, and then there's a question of whether you can transition to apixaban. So in terms of how long to treat a PE, what we're always looking at is transient risk or persistent risk, meaning what's the risk factor that's there that tells us how long the person needs to be treated. And sort of the way to think of it is low, medium, and high in terms of risk. So surgery is considered the lowest risk factor, transient risk, roughly 3% risk of recurrent clot at 5 years. Estrogen, pregnancy, airplane flights fall into the middle, and cancer is the high risk category. So when you're deciding how long to treat, and you have this handy dandy chart to help guide you, for a PE that's provoked with a transient risk, you're doing at least 3 months, but not necessarily longer. For a PE that's unprovoked or there's a persistent risk, you would want to extend therapy for 6 to 12 months. And this gets into some of the ambiguity among providers of how you decide 6 months versus 12 months. The recommendation from the guidelines is you should be reassessing every year as opposed to just keeping people on anticoagulation indefinitely. So in terms of whether to repeat imaging, so if you see a PE, do you need to image again? If there's persistent symptoms, you would clinically because you're trying to see what happens. This I just think is interesting. So it's an old study, but they looked at PEs that were people who had an initial CTA or a VQ and were re-imaged for whatever reason, and found that of the people who had a PE on an initial study, 81% were gone within a month, and central clots resolved faster. And there was a significant number of people whose clots resolved within a week of anticoagulation. And then they aggregated all different studies going back to the 1960s. And so I guess probably you could say the imaging quality may not have been as good. But there was significant resolution of clot going back that far within a month of anticoagulation. So how do we decide who gets extended anticoagulation? And this is done differently in different places, but one thing that works is using biomarkers as a predictor of risk. And we do, at Sinai, we do the combination of D-dimer and factor VIII. So it's an old study, this initial factor VIII study from 2000, where basically people were anticoagulated. A month later, they checked a D-dimer level, a factor VIII level, and depending where the factor VIII level fell, they used it as a predictor for risk. So people who had a lower factor VIII had a lower risk. This is going out to 7 years off of anticoagulation. People who had a higher factor VIII and they used above the 90th percentile, which is high, meaning not the same as the cutoff for normal or abnormal in the lab, found that there was a higher risk of recurrence, and the big rise in risk was within the first 2 years. Later, this group from Italy combined D-dimer and factor VIII. Just to note, they used 75th percentile as their cutoff. So used the same way. People were anticoagulated, they stopped anticoagulation, waited a month, and measured those levels. And people who had a low D-dimer factor VIII combo were considered low risk and could stay off of anticoagulation. People where both were high should be on it. The way I use it is I measure a D-dimer factor VIII at the end of when we're anticoagulating. If the numbers are high, I would not stop it. If the numbers are low, I would stop it, then check it again in 30 days. And that way you sort of have those two data points, one on anticoagulation and one off, and you can look at risk based on that. And then finally, in terms of this question of continuing anticoagulation longer, so both apixaban and rivaroxaban were studied in people who were anticoagulated for 6 to 12 months, meaning they got their treatment. And then the question was, what do we do now? And so in the apixaban study, compared to placebo, people got either full treatment dose apixaban continued, a lower dose of apixaban, or placebo. And what they saw was that there was, going out to a year, a very low rate of recurrence on either dose of apixaban, a higher rate on nothing. And in terms of bleeding, the bleeding risk was similar. And so the conclusion was, in people where you're concerned that there may be a risk, apixaban at a low dose is probably a good option for this extended therapy. Rivaroxaban was very similar. The only difference is they also did 2 doses. They compared to aspirin. And they also saw, going out to a year, that continuing rivaroxaban as opposed to switching to aspirin lowered the risk of clot, and the trade-off in bleeding was not significant. And so this gives us another option of how to perhaps extend therapy in patients where you don't feel fully comfortable stopping or switching to aspirin. And that's it. Thank you.